Hello, everybody. Welcome to Grand Rounds. Today it's critical care, and really pleased and honored to present the speaker. Dr. Jason Waechter is a cardiac anesthesiologist and an intensivist, and he works in critical care and cardiac anesthesia in Calgary, Alberta. Jason's interests, he's just FYI, he's UBC alumni as well, but he's also trained in other places, including Manitoba and Alberta, so he's done his fellowships elsewhere. Jason's passion and interest is competency-based medical education and critical thinking. I also like to mention he's the founder of probably one of the best online teaching modules I've ever used or been able to have access to, and that's teachingmedicine.com. So really proud of Jason for that. So anyways, without further ado, I'd like to introduce Jason.
Thank you. Just thanks to Dr. Sarunas for inviting me to have the opportunity to give this talk. St. Paul's gives me a lot of memories. I think this is probably the first hospital when I did overnight call as a medical student on a general surgery rotation. And even though I did 4 years of anesthesia here after I finished my residency, my most intense memories, I think, were as a medical student. So a little bit about me. My last name rhymes with Waechter, like the cereal. I did medical school here, finished in 1997. I work in, as Dimitri said, critical care, cardiac anesthesia. I have a strong interest in medical education, and I spend a lot of money on my website, teachingmedicine.com. So it's lunchtime, and it's take a deep breath in, everybody, and then relax, exhale, and lower your expectations for this talk. These are the objectives I want to try to cover in the 45 minutes. So attempt a definition at clinical reasoning, discuss some of the causes and the incidents of misdiagnosis, see if we can take apart the steps that are performed when you make a diagnosis, and then try to understand bias and what might be able to be done to reduce bias or errors in the diagnostic process. Critical thinking and clinical reasoning are kind of the same in my head, so I did a Google search, and this is the definition that popped up: an objective analysis and evaluation of an issue in order to form a judgment. I think that's a fairly broad but reasonably accurate definition. Clinical reasoning has a slightly different definition, so identification of clinical information, interpretation of this data, generation of a hypothesis, testing your hypothesis, and then finally establishing a most probable or working diagnosis. So a quick overview of why this is an important topic. It's because errors in clinical reasoning lead to diagnostic errors, which result in patient harm. Clinical reasoning errors are not the only form of error that can result in a diagnostic error, and patient harm is not the only outcome. But what I want to do is just focus on the thought process that we undergo and the decisions that we make when we are in the process of making a diagnosis. The Institute of Medicine states that it's likely most of us will experience a diagnostic error, and sometimes with extremely harmful consequences. So it's a common problem. There is, in fact, a Society to Improve Diagnosis in Medicine, SIDM. They have a website, improveddiagnosis.org, and they have an annual conference. I attended the 2018 one in November, and it was excellent. If anybody is interested in misdiagnosis or clinical reasoning, this would be a really valuable conference to go to. This one coming up is in November in Washington. So definition of a diagnostic error. Prior to attending this conference this year, my definition basically was if you get the wrong diagnosis. But it's a little bit more than that. You have to obtain the correct diagnosis, of course, but you should obtain it in a timely fashion, and you should communicate the diagnosis to the patients. And so the ACT for better diagnosis, the word ACT is an acronym for accurate, communicated, and timely. And the position of the SIDM now is that if you fail on any one of those three definitions, you have committed a misdiagnosis. So an accurate diagnosis requires that it's timely and also communicated to the patient. I have a little bit of audience participation, and so you can get your phones out. I think it's limited. I forgot to increase my plan. I think 20 people can vote on your phone, and in a few slides from now, I'll tell you exactly what to do. A little bit more on the incidence of misdiagnosis. So it's now considered to be a medical crisis, and they use the image of an iceberg to show that we're just sort of understanding the scope of the problem. Diagnostic errors account for 12% of hospital adverse events, are responsible for 74,000 deaths per year. And this is American data, and I don't have the date or the year that this was collected. And they estimate up to 18 million diagnostic errors per year are committed. This is data from a malpractice insurance company from the United States. You can see along the bottom the sample size is close to 600, and the years that data was collected was between 2002 and 2007. And the light blue bar is the number of claims, and the dark blue bar is the total dollar cost. And you can see that the diagnosis-related errors far exceed the incidence of all the other sources of error. At the conference, there was a report put out by a malpractice company called Coveris, and this is similar to the graph that I just showed you, data from 2013 through 2017. And the sample size here is over 10,000. And what you can see, the red bars are the number of percentage of claims, and the gray bar is the dollar value. And what you can see here is still the frequency of diagnostic errors exceeds the frequency of all the other errors as well. And so this has not improved from the early 2000s into the later 2000s. 53% of the diagnosis-related claims are caused by poor clinical decision-making. 54% of the claims are high severity, and 36% of them resulted in death. So these are not insignificant diagnostic errors, and they occur very frequently. They also drilled down the data to look at where in the clinical judgment process were these errors occurring. And you can see on the far left there, the most common is too narrow of a diagnostic focus. And I just want to plant a seed into your brain to get you to think about why a diagnostic focus might be too narrow. There's inappropriate or inadequate testing, misinterpretation of test results, failure to adequately assess a patient's condition, and at the far end is insufficient history. This graph is a little bit similar to the one you saw before. Starting at the top, these are the first steps that are performed when you're making a diagnosis, and then as you work your way down the slide. And I highlighted the three areas that were the three most prevalent causes of error, and they include the basic fundamentals of making a diagnosis. So errors within the history and physical assessment, errors with ordering tests, and errors with interpreting tests. Okay, so on the next slide, what you're going to do is send a text. So it's just send the letters JAS and send the text to 37607, and I'll go on to the next slide and see if this works. So you send the three letters to 37607. It should give you a response. And then after you get a response, you can type in A, B, C, or D to indicate how you're voting to answer this question. And it might take a moment to get the response. Yeah, but only there's only 5 people who voted here, so you should be good. There's sometimes about a 30-second delay from when you submit to when you get a response. Okay, the next couple slides will be actual questions where your answers matter. So this is case number 1, and it's a patient who has difficulty breathing. And the question for you is, what is the most probable diagnosis? You can vote now.
May I ask a question while we go?
Yeah, sure.
So you asked, what's the most probable diagnosis? But wouldn't the correct question to be asked, which one do you need to include or exclude right now, most importantly?
So that the question was, instead of asking for the most probable, which is the diagnosis that needs to be included or excluded at this time? And in the next couple of slides, I'll explain why I asked the question the way I did. Okay, we have 19 results. So let's see if I can show results, and we'll see what we've got. Okay, so heart failure, pneumonia, asthma, none of the above. The question now is, how confident are you with your answer? Very confident, quite confident, low confidence, or no confidence? All right, that's 20. Let's see. Okay, so half of you had no confidence in your answer at all. Maybe a third of you had a low amount of confidence. Nobody had high confidence, and a few people were quite confident. How many diseases could cause difficulty breathing? There's actually a point to all these questions, and I'll wrap it up for you in the next couple slides. We're getting there, getting close. Oh, look at that. It's taking more than 20 people. Okay, most of you say 50 or more. Okay, so basic statistics. The less data you have, the more possibilities exist. And as you guys just demonstrated, I gave you one piece of data. I didn't tell you age or gender or anything else. I just said a patient had difficulty breathing, and you guys identified that there could be in excess of 50 different causes of difficulty breathing. And obviously, the more data you collect, the fewer probable diagnoses or possibilities exist. So if we added difficulty breathing with productive cough, with 3 days, with fever, it changes your differential diagnosis considerably. So let's analyze this case that you just did. If 50 cases can cause difficulty breathing, and if every disease has the same prevalence, what are the chances that your choice is correct? Somebody said 2%. Yeah, because if you have 50 choices, you've got a 1 in 50 chance. So the probability that if every disease had equal prevalence, you'd have a 2% chance of being correct. If 50 diseases cause difficulty breathing, but 5 diseases are the cause 95% of the time, then what are your chances of being correct? Yeah, so if you chose one of the ones in the top 5, you've got essentially a 1 in 5 chance, so 20% chance. If you chose one of the bottom 45 answers, you have a 0.1%, a 1 in 1,000 chance of being correct. And so comparing when you're provided with one piece of data and you acknowledge there could be 50 different options, or maybe if within those 50 options, arbitrarily, let's say that 5 of them could represent the vast majority, statistically speaking, your confidence should match your statistical probability of being correct. And so you guys are really good. Your confidence scores were very low. And when I gave this to a class of medical students, the confidence rating was significantly higher. And so it underscores a discrepancy between confidence and perhaps statistics. And indeed, overconfidence has been recognized as a cause of diagnostic error in medicine. And they state physicians in general underappreciate the likelihood that their diseases are wrong. And this statement underpins many of the biases that I'm going to give you a brief description of in the following slides. Here's a similar question. Difficulty breathing. A 2-year-old healthy girl presents with difficulty breathing. What is your differential diagnosis? Aspirated a toy. Yeah. Anything else? Allergic reaction, infection. What about a 16-year-old healthy boy presents with difficulty breathing? What's that? Asthma. Anything else? Pneumothorax. What about a 30-year-old female with difficulty breathing? Healthy. PE. Anxiety. What about a 70-year-old man with a chronic heart failure history presents with difficulty breathing? Pulmonary edema. Okay, so every case here, it was essentially the same. The chief complaint is difficulty breathing. And the question I have for you is, are you aware of how your thinking changed when only the gender and the age of the patient was different? Of course, the last one has a little extra there. Is it possible that pneumonia could be the correct diagnosis in all these patients? Sure it is. How many of us identified pneumonia? It wasn't near the top. Okay, congratulations to the one guy who did. Okay, let's build a case. This is going to be slightly painful, and I apologize, but there, again, is going to be a point to all of this. So 25-year-old female presents with abdominal pain. What do we know so far?
She's pregnant until proven otherwise.
She's pregnant until proven otherwise. Yes, we also know her age. We know the gender. And she has, so we have 3 pieces of data. That's what we know without making any assumptions. That's all we know. And so when we're working through the diagnostic process, our first job is to explore the chief complaint. And we're taught in medical school to ask all these questions. When did it start? What makes it better? What makes it worse? And so we ask all these 10 or 15 questions about the chief complaint. And then when we've beaten that one chief complaint to death and we've asked everything we can think about it, we need to do something else. And we need to use an organized approach to find more symptoms. We need to explore the history. And so we can do this either disorganized, haphazard, or we can do it in an organized way, which is what I'll suggest. And you could do it by organ system, by disease, or review of systems. So let's say we choose to explore this patient using organ systems. And if you think, okay, a female with abdominal pain, the reproductive organ system is going to be a system that you need to ask a lot of questions about. The gastrointestinal system needs to be a system you need to ask a lot of questions about. And if you get a hit, if you're asking all these questions and the patient says, yes, I also have that symptom, now we have to go back to exploring that symptom and ask all the 10 or 15 questions that we have to ask about that. We could also explore the symptoms by disease. So you could think of all the diseases that perhaps a female this age with abdominal pain might have. And this is a little bit more difficult because this requires that you possess the knowledge of the diseases in order to ask the questions about the disease. And finally, you could do a review of systems. And the reason to do a review of systems is, what if your initial thought process did not capture a disease from an alternate system that you didn't think about? So even though it's not probable, what if abdominal ischemia or bowel ischemia was the cause, and you didn't ask any cardiovascular related questions? You could completely miss the diagnosis because of an error of omission. This is my level of enthusiasm for asking questions on review of systems, because there are always no questions. And if you're doing a neuro history on someone with abdominal pain, the probability that you're going to get a yes answer is very low. So I don't enjoy doing them, but I'm not suggesting that that's correct. I'm just saying review of systems for me is something that's really boring to do, and that is my personal bias. Not doing it, it exposes me to error. So let's just take a look at the amount of work that we've done so far. When you take a history, you've got a chief complaint, you have a symptom that you explore, you use an organized search for finding other symptoms, and when you have a new symptom found, you explore that symptom, and you keep going around and around until you feel like you've got all the symptoms, and this is what we call the history of presenting illness. And then you add to that the other components of the history, and that encapsulates just taking a history. In addition to taking the history and collecting all this data, your brain has to do something else. It has to create a differential diagnosis. And so what I'm trying to point out is how much work your brain is doing while you are simply doing a history. And so when you're asking a question on history, first of all, you have to decide what questions to ask. That's a decision. You need to make a determination whether the patient understood you. You need to decide if you understand the answer that the patient's giving you, and whether or not they even answered your question. So even with one question, there are multiple decisions that are occurring, and this is quite a bit of work. As you are collecting this data and you have created a differential in your head, you are making another decision. For every piece of data that you collect, you need to decide, does this piece of data increase the probability of a diagnosis on my list? Does it decrease, or is it completely irrelevant? So if we had a short history like this, and we had a list of diagnoses, what your brain is doing is it is assigning, or should be assigning, all of the relevant data to the different boxes that either increase or decrease the probability of those diseases. So your brain is performing all of these mental tasks, analyzing the data. And to mathematically quantify, let's say the history had 25 pieces of data, and your differential diagnosis had 5 items. So this is not unreasonable. And for each piece of data, you're making a decision, do I increase, decrease, or have no impact on each item in my differential? You are forced to either ignore the data or make as many as 125 decisions. So that's just analyzing the history. That doesn't include taking the history or doing the physical exam or the investigations. So I used to be the course director for the cardiovascular undergrad course here from 2006 through 2010, and we would write cases. And so I dug up one of my cases from 2009, and I counted how many items were in the history, how many items were in the physical exam, and how many pieces of data from investigations we provided. And this was the answer, 36, 32, 23, for a total of 91 pieces of data. The differential diagnosis probably included as many as 5 diseases, and so 91 times 5 is 450 decisions. So it's a lot of work that our brains are doing when we are performing a diagnosis. We have to collect and analyze history, physical exam data, and investigations data. So it might not, therefore, be surprising that when we have this enormous workload to perform a task, the most common errors occur in the individual components of that workload. And that's been borne out by the malpractice data. So why am I spending so many slides to show you? One, to show you that it's an enormous amount of work to make a diagnosis, and to show you what the normal steps are. If you deviate from any of these steps, meaning you don't collect the data, or you have data available to you and you don't analyze it, then you're increasing the probability of making an error. So in order to understand how a system breaks, like the human body, you first have to understand how it works. Okay, that's 3 out of 5 items in the objectives, and let's move on to understanding the bias within the diagnosis. So, as I just mentioned, in order to avoid a misdiagnosis, you probably need to understand the genesis of a misdiagnosis. And in order to know how something breaks, you first have to understand how it works properly. This is one of the articles that I think is very impacting on our understanding of diagnostic error. The primary author is Mark Graeber, who incidentally is also the founder of the Society to Improve Diagnosis in Medicine. This is published in 2005, so it's not super fresh, and I'm going to go through the results because I think they're quite interesting. How are we doing for time? 12:30, okay. So they analyzed 100 cases, and they found that 7 of the cases were no fault, so either the patient was deceptive or there was a masked or unusual presentation. So they analyzed data from 93 cases, and the cases could contain more than one error. And this graph, this pie graph here, shows the percentage of system errors, cognitive errors, or both. And what I want to highlight is that cognitive errors alone were 28%, and cognitive errors with system errors were 46%. So the cognitive errors occupy a large percentage of this pie chart. They found 228 system errors, 321 cognitive errors, and on average, almost 6 cognitive errors per case. And I just want to focus on these cognitive errors. So they broke them down into faulty knowledge, faulty data gathering, faulty information processing, and faulty verification. One of the first observations that pops out is that lack of knowledge does not seem to account for a very large percentage of these diagnostic errors. Data gathering. So in this category, they found that there was a faulty workup. For example, a delayed diagnosis of drug-related lupus, and it's because the old medical records were not looked at. Multiple cases of history and physical. So in this case, there was incomplete history. So what this shows is that the errors that are responsible, the cause of these errors are fairly easy tasks. It's not difficult to look up old records. It's not difficult to do a complete history. It might not even take a lot of experience to do these types of activities. And so I put this picture up because when there's an ICU consult and I go to emerge and the patient has a long list of medical problems, and this is the stack of old charts, this is my amount of enthusiasm to read through all these records cover to cover. Faulty information processing. So this example here, there's context generation. How do you interpret chest pain in the context of other data available to you? And in this example, the troponins were elevated, and so a diagnosis of a cardiac problem was made when in fact the true source of the chest pain was a missed perforated ulcer. Over or underestimating the importance of data. So a patient who was diagnosed with sepsis who had a chronically elevated white count is the example that they used there. A couple months ago, I was in the CV ICU, and the trainee I was working with, who's a really good trainee, cardiology R5, and we were doing rounds on a patient who had a bad heart and had low mixed venous oxygenation. And so the resident said, well, this guy has low cardiac output. And I said, well, the lactate is down, the creatinine's down, the urine output is up, the patient looked good, he felt good. There were some other physical findings that suggested a normal cardiac output. And so we had a discussion that focused around incorporating all of the data that's available to us and being aware of how heavily we weight each individual piece of data. And so the question I had for him was, why are you putting so much emphasis on one piece of data when you have multiple other pieces of data that are suggesting an alternative conclusion? Faulty information processing, so faulty detection, missed pneumothorax on chest x-ray. This is actually one of the competencies, not chest x-ray per se, but ECGs. And there's vast amounts of literature to indicate that the diagnostic competency of medical students, residents, and physicians who have finished their training with respect to ECG interpretation skills is below what it should be. Failed heuristics. So heuristics are mental shortcuts. And the example they have is a patient who was diagnosed with bronchitis, but who had a true diagnosis of a pulmonary embolism. And it probably doesn't take a lot of imagination if you're working in an emergency department and there's a virus going around and you're having a high volume of patients come in with cough, and the true diagnosis 9 times out of 10 is going to be a viral bronchitis. It would be easy to apply the same diagnosis to the 10th patient who has a different diagnosis, because you just correctly used the shortcut and you were provided positive reinforcement because you were actually correct. Faulty verification. So the definition of premature closure is a readiness to accept a diagnosis before it was verified. And the example they used is a patient with trauma who had a ruptured spleen, and they were given the diagnosis of musculoskeletal pain. Or another example, failure to follow up on the tests. Wrong diagnosis of urosepsis when there was no urinalysis ever ordered. So what they concluded is multiple factors or multiple errors contributed to each case. There was a tendency for one error to lead to another. Defective knowledge was not a common cause of error, and premature closure occurred more than any other cognitive error. So premature closure was the most common. And there's data to show that experienced physicians are just as likely to commit a premature closure error as less experienced physicians, and there's also a reference to suggest older physicians might be even more at risk. So moving from what to why, in many of these examples, we could see the errors that were made were fairly easy. It would not require extensive experience to go and do a complete history or to make sure that you check the old charts. And so there's descriptions about what these errors are. I think the literature is quite sparse on explaining why these occur, and equally so, understanding what we can do to prevent them. So these are hard questions to answer. There's a paper from a psychology journal back in 1990 that describes a term called satisficing, and this basically means when you arrive at an explanation for the problem, you will stop. You will stop collecting data and you will stop analyzing data. And if the explanation that you have arrived at is correct, then it's entirely logical that you would stop. And so this is something that our brains inherently do, and this is described as one of the reasons why we have bias or commit diagnostic errors, because we stop too early in the diagnostic process. This is a table from Academic Medicine 2011. It's not an exhaustive list of biases, And in fact, there have been over 100 biases that have been described. But I wanted to focus on the red rectangles there, common denominators. So anchoring is a bias, and that's a tendency to lock on to a diagnosis too early. So if you are locking on to a process too early, it means you've stopped continuing thinking about other diagnoses that might be occurring. Premature closure is when the diagnostic making procedure ends too soon. Search satisficing is when you call off a search. And unpacking principle is when you fail to elicit all the relevant information. You might get a couple pieces of data, and then you decide, I'm stopping there. So imagine it's 3 a.m., you've been working all day and half the night, you're tired and hungry, maybe feeling cold, you've got a full day tomorrow. How is this going to impact your processing or your diagnostic decision making? And this is not something I've read about in the literature. This is my own personal opinion, but desire is one of our primary vulnerabilities, and desire will lead us to bias, and the bias will lead us to errors in judgment. And so these are obviously stupid questions. The answer to each of these is yes. Do you desire to rest when you're tired, eat when you're hungry, see all your patients in a timely fashion? And so because these are inherent desires that we have, they're logical, they're reasonable, there's nothing out of the ordinary for any of these, they will lead us to behave differently. For example, you will perform less work per patient, spend less time per patient, or use efficient processes if you're under the gun for time and you're falling behind. And these are all logical solutions, and we all do them, but unfortunately they increase the probability that we can make an error. There's in the literature for critical thinking or diagnostic error, there's described two types of thinking. Type 1 is pattern recognition, which is faster, easier, and less work. And then there's type 2, which is the deeper dive, which is the more analytical process. And when we use both of these processes in the diagnostic process, it's called dual processing theory. And so we can jump back and forth between type 1 and type 2. And so which type should we be using? Well, if you can get the right diagnosis with type 1, why would you use type 2? And the answer is there's probably no advantage. But the problem is we don't know when we have the right diagnosis. And so we might be using shortcuts in a patient who looks reasonably simple and straightforward, and we don't do a deep enough dive and explore all of the data, or if there are some inconsistencies with the data, we might not make the effort to understand or explain all of this. Here's another scenario. Let's say you've analyzed 6 pieces of data on your patient and you make a diagnosis and you've been treating them for 2 days, and then 3 more pieces of data become available and somebody else makes a different diagnosis based on the 9 pieces of data. What will you think and how will you feel? And you're probably not going to feel very good, because at that point in time you're going to realize that you were wrong. So you might have a judgmental reaction that you failed or you did a bad thing. You might have an emotional reaction of fear or guilt. And our brains do not enjoy this experience or this process. We try to reject it. And this is normal. And what's important for us to realize is how this scenario impacts the decision-making in the diagnostic process. How will these thoughts and emotions impact how we collect data and how we analyze the data? If our brain is resisting the truth that we are wrong, our brain is going to play tricks on us to try to convince us that we were not wrong. In a simulator session I did with a group of medical students in Calgary in the last few months, in the debrief, one of the medical students, and she was in her final year of medical school, said, I locked onto infection at the start. So it was a case of decreased level of consciousness, and I can't remember what the real diagnosis was. And I said, oh, well, that's really interesting. What do you mean you locked onto it? I said, does that mean you had a high degree of confidence at the beginning of the case that infection was the correct diagnosis? And she said, yes. And I said, well, how much data did you have at the beginning of the case? And she goes, well, not very much. I said, what did this do then to your brain as you proceeded through the rest of the simulation? She goes, well, I was looking for data to support my diagnosis. And so she, without really any significant amount of coaching, basically said she arrived at the conclusion first and then was seeking data to support her conclusion. Other desires that we probably have when we're making a diagnosis, you want to get the diagnosis early because that makes you feel a little bit smarter. We have a desire to be certain. Uncertainty makes us feel uncomfortable. And there is an association between uncertainty and not knowing the answer, and perhaps a relationship between uncertainty and failure. Our jobs are to confidently tell the patient what the diagnosis is. And so if we are not confident when we're communicating to patients, maybe that's going to show us as not as smart or not very good at our jobs. The same cardiology resident I was working with said, and this wasn't his quote, but he was quoting another type of doctor, and maybe you can guess what kind of doctor that is. It is better to be confidently wrong than it is to be tentatively right in the operating room. So just a reminder that overconfidence is one of the identified causes of diagnostic error. Okay, the next slide will have a voting thing for you. So here's an interesting case I want to share with you. 51-year-old male, 3 days onset of productive cough, fever, shortness of breath, low appetite, low energy, non-smoker, no exposures, no travel, works in an office. Review of systems was pretty much all negative. He's still a non-smoker again. Previously healthy, no medications. On exam, I'll let you read all those details. And in the end, the eMERGE doc says the diagnosis is an uncomplicated community-acquired pneumonia, and the patient is sent home on azithromycin. 5 days later, he returns to his family doctor. What should have been the most probable diagnosis? We got 16 votes. Other. So I'm curious, the people who voted other, what were you thinking? Anybody want to offer a suggestion?
Pneumonia.
Pneumonia?
You're asking what should have been the diagnosis at the time the emergency doctor saw the patient, right?
That's right.
Pneumonia.
You say pneumonia? You other nod? Yeah. So...
But again, it's not about what should have been or what's my pretest, what's my probability for pneumonia and other. So that's the most important thing, really.
So one of the things that I tried to do, and I succeeded in getting the answer that I wanted with medical students, but I didn't really succeed with you guys, is to take a case that very clearly provided data that strongly supported a diagnosis of community-acquired pneumonia, and then I wrapped it up in a bunch of garbage. I told you this was an interesting case, but it's not. I asked you a question, what should have been the diagnosis, suggesting, without using data, but maybe emotionally or otherwise, trying to manipulate you into thinking that there was a different diagnosis. And this is a fake case, and so if you said, all of the data that I read about that was presented in the case supports the most probable diagnosis of being pneumonia, regardless of all the other garbage that I tried to wrap this up in a context with, then you did a great job, so good work. Better training for clinical reasoning. This is an area that likely has more questions than answers. And there's lots of literature published about how to train physicians to be better thinkers or to think more logically. There's a number of different strategies. One of the strategies that I'll just briefly go over, and then I'll be done pretty soon, is called debiasing. So if you can imagine that we all have these inherent biases, if you go through a process that debiases you, you should come out the other end a more logical and more accurate thinker. And so this is work from Pat Crosscarry. He's an emerge doc in Halifax, and he suggests that in trying to reduce the bias of premature closure, we consider alternative diagnoses. We make sure we generate a differential diagnosis as opposed to just one diagnosis, and we always rule out worst case scenario. In order to do this, on some level though, we have to admit fairly early on that we might be wrong, because there's no point in generating a differential diagnosis if you know one of the diagnoses is correct. You're just wasting your time adding additional alternative diagnoses that you already know are incorrect. So you must be able to force yourself to admit that you might be wrong. Anchoring bias. So getting fixated on something. So the debiasing strategy, avoid sticking with early impressions, make sure you seek more information. And this approach requires that we hang on to uncertainty a little bit longer. Confirmation bias, so this is basically creating your conclusion first and then collecting your data second. So some of the strategies: try to disconfirm your initial diagnosis, argue both for and against, and ensure you have alternative diagnoses considered. And this, of course, requires that we admit that we might be wrong. And then the visceral bias or affective, this is an emotional component. So if you have a patient population that you might not be entirely happy to provide care for, this can influence your decision making. If your feelings are positive, like maybe this patient reminds me of my mom or reminds me of my dad, you might go a little over or a little extra. And so the suggestion here, one of them is act calm no matter how you feel. And I just want to ask anybody who is in relationships or who has children, is this something that you can do at home 100% of the time? Absolutely. And so this requires that we separate our feelings from our thoughts. And so the debiasing, I think I would, in theory, agree with all these strategies. I'm not sure I could always be doing them. And the debiasing strategy seems to inherently oppose a lot of the innate desires that I have, which is to be right and a desire to get rid of uncertainty in the process. This is my second last slide. I would consider this presentation to be a success if you walk away and you have an increased awareness of whether you are using type 1 or type 2 thinking when you're making a diagnosis, if you are aware of the diagnostic workload, if you are related to your desires as they pertain to the diagnostic process, and if you are aware of the decisions that you're making. So if it's 2 a.m. and you're called to a consult and emerge, and you see the patient is there and you see 6 volumes of an old chart, are you aware of your decision not to read through the old chart, and are you aware of how that might impact your final diagnosis? Thank you for your time. I'm going to go to this. What are you getting up for? I'm going to this meeting on diagnostic error. I think it's a fantastic meeting, and if anybody is interested in this topic, I would strongly suggest you go to that too. Thanks for your time.
Thanks, Jason. My excuse has always been very debated. I can't take the SD, but I can't hang out too much longer. Seriously, great talk. Thank you very much. A lot of key points there. I want to open up to the floor and see if anybody has any comments or questions.
Yeah.
So, to the point, all of those charts, we don't use charts anymore, or used to call that congested chart over here. made that an active process. I would suggest that that should be a passive process. That taking a history and listening to a history, you've got to ask the question. And I'm not sure if that's something that you talk about when you were diagnosed.
Yeah, so the question or the comment is about taking a history as more of a passive process, or data collection as a passive process as opposed to an active process. And I would agree, for the history, you want to give the opportunity to the patient to tell their story, so that would be passive. Of course, there will be some questions you want to ask, and that will be active. But then data collection is not limited to history. There's also physical exam, which is an active process, and the decision about what tests to order will also be active decision making.
Just referring to the history.
Yeah, no, I would agree. There's going to be a passive and active component for sure. Yeah.
All of the new artificial intelligence stuff is, I guess, type 1, where there's just pattern recognition by some goofy computer. So there's obviously no logical plot there. Now, you pointed out that type 1 is an efficient way of doing things, but you still have to have type 2 reasoning. Do you know, is there any research on where artificial intelligence type 1 reasoning makes its errors, so that when I'm using type 1 reasoning, I can sort of be aware of where I'm most likely to make an error?
So the question is about artificial intelligence and the use of type 1 thinking, and is there any evidence regarding the types of errors that artificial intelligence might make in the diagnostic process? I've looked for some artificial intelligence literature. It is all, at this point in time, very, very preliminary, and I don't think it answers the question that you asked. And I would probably agree that it is a type 1 type of process that the AI would be going through. The one thing that it would be different, though, is that it might be less prone to bias. So the data collection and data analysis that AI would go through would be consistent regardless of time of day, regardless of how many patients there are. And so there could be some advantages to AI using the same type 1 system that might show advantage or superiority over the human doing the same task. But I don't know.
And I suppose when it's appropriate, then certain criteria are weighted with the same importance every single time. Give us a scoring tool for the diagnosis of some condition. We, as humans, we might favor one aspect of that diagnosis more than other ones, when the literature would support having whatever prevalent,
And AI doesn't usually, with the ones I've seen, doesn't usually come up with, this is the diagnosis. It says, like, there's a 96% chance it's this and an 18% chance it's that. And so that's avoiding that, and there's that bias of that initial, oh, this is the most likely diagnosis, therefore this is the diagnosis.
Yeah, and the AI makes it differential. It never just gives you one answer, which is what sometimes we do. Yes?
So basically that was what I was going to say in answer to the AI question, which is AI will give you differentials, and as long as they generate probabilities that you can work from, devise hypotheses to test those probabilities, revise the probabilities on the basis of the hypotheses, then you can use AI in a really useful fashion to add to your diagnosis. And what I just wanted to say is, I thank you for bringing all these things to our attention, because in fact medicine is not binary. Medicine is probabilistic. You see a patient and you have a differential diagnosis, and you assign probabilities in your mind to each of those possible differential diagnoses. Then you weight them on the, can I miss this? Can I afford to miss this? You weight them differently. And then you further refine your thinking to design an approach to test your hypotheses. So the most important thing for us to remember, I think, is it's not about being right or wrong. It's about having an approach and probabilities and doing the right thing, and just working with probabilities and statistics, and never being satisfied. that you're right. You know, if you're 95%, maybe you can get to 98%.
Yeah, I agree.
And so thanks for that talk.
And just wanted to ask you, any thoughts or considerations across all this reading, thinking about this in terms of educating? Like, I was explaining to you right now, what I see more and more is, you know, you'll see a new mission come in and, you know, clean resident, you know, that's done a battery of tests that are 3/4 are irrelevant. I feel like we're casting in that now, just looking for stuff, like, you know, that diagnosis, that misdiagnosis, that disruptor, that also because it's positive trope. Everybody in our unit has a trope done, not once, but 3 times. Everyone's got a TSH, everyone's got all these improbable tests, and it really frightens me because I think, you know, that's what teaching is now. It's just like, hey, this is the panel for, you know, back in the day it was a CBC panel or a light screen panel, whatever it is. Now this panel is just huge, and so I don't know how you approach, you know, education.
And then you find a little thing that you need to work out, right?
Right, so it leads to other sort of.
Yeah, so that's a good question. How do we train the trainees not to just throw a wide net of tests and see what they can catch? So I promote, if you have created a differential diagnosis, then you should be asking a question with every test that you order. And every result that comes back should be applied either as increases or decreases the probability of your diagnosis. If it doesn't increase or decrease the probability of any of your diagnoses, then you could argue it was a wasted test in that it does not help differentiate or change your thinking about actually determining what the most probable diagnosis is.
Just a question back here, kind of
Yeah.
relating to that. As residents, I feel like there's a lot of pressure on us to kind of prove our thinking via tests overnight, especially. And it depends on, of course, what attending you end up reviewing with the next morning, and it becomes almost a reflexive behavior of, let's just order all this to prove my critical thinking skills instead of just looking at like what your note was and what your thought process was from that. I'm not sure if you have any suggestions on how to change that at a more cultural level. And also, secondary question is, I think there's a lot of pressure on us to rattle off the top of our head, like, here's all the knowledge I have, and be very certain about our diagnosis, etc. How do you recommend attendings kind of go about how they pose questions or how they kind of structure their education so that diagnostic uncertainty and exploration of inductive reasoning is encouraged in the clinical setting where things are pretty fast-paced and hectic?
I think that's a really difficult question. So you're asking how to get the supervisors, the mentors, or the staff physicians to value and encourage and assess the probabilistic and critical thinking or clinical reasoning processes. And if what we value, if what we communicate to you is we value multiple tests being ordered because it reduces our workload, and we don't get in trouble for ordering all the tests, but I could say, well, you ordered all these tests, and if something pops up, it makes my life easier. So I think there's a culture shift that might be required, or we need to be very clear about what the primary learning objectives are. And if the primary learning objective is to collect relevant data and not collect irrelevant data, be accountable for all these extra irrelevant tests that are ordered, all of a sudden we're going to be changing the behavior of the residents. So I think it's not an easy question to answer. There's a couple things that the focus could be different, I think, that might improve the situation. 1, 2.
I just have one comment. Like, I'm doing St. Paul's ICU for the first time, and here it's like when you want to do the order entry, you got to do it to SEM yourself, and often it asks you, even for like a CBC, like what's the indication, and like just from this week, I already see myself asking myself, like, oh, do we really need this test? Because before it's like, oh, if this patient doesn't have a CBC today, we should get a CBC for today. But when I ask you, like, why do you want it? You're like, maybe I don't need it. So like that's one thing that I found helpful, and it's making me re-examine why I'm ordering even these routine tests.
That's good, yeah. So automated cues or prompts to justify why you might be ordering what you're ordering. Yeah.
So just to respond to, I think that's really a very astute observation. I think that by a resident.
Can you speak up?
Yeah, sorry. I think that's a very astute observation by the resident. I think there are different times. Diagnostic reasoning doesn't take the same shape at 2 in the morning as it does it in an office setting versus an emergency setting versus an OR. So I think that we have to, I totally agree. Seeing someone at 2 in the morning and having the same approach and differential and the same thought processes, I think a little bit, I don't think it's appropriate. I mean, we're doing different things at different times. That we're able to defend all of this at a time when we don't really need to do it. I think there's ways to if we're teaching, and that I think leads to remembering everything and doing everything and taking contact.
Yeah.
I'll just add that I think a lot, well, I can't speak for everyone in all situations, but sometimes we feel like the pressure is coming from our attendings or outside, but really it's our own, this pressure is being on ourselves to be right, or to feel like we got the right answer by the morning. And so I'm not discounting that you might feel that pressure is being put on externally, but I think a lot of pressure is coming internally as well.
I think it's good to have that awareness and how the pressure you might be putting on yourself influences the decisions that you make. Yeah, that's really important.
Great. I think it looks like it's time. Jason, thanks again for coming. Really appreciate that talk. Great talk.
Thank you. Yeah. Let me just put a note in my phone.
A lot of times, like, talk about things they do with patients that I referred to as possible. So, like, neither of them had any indication of hospital. That means $280. I complained bitterly. One of them was going there was completely nothing to show us. The other reason
Because the patient turns here.
it's like,
You didn't even think about
I don't know how many you see or medical and then medical legal opens up too. Who even knows if that was the cause of his
Oh, yeah. Of course.
I teach exactly. Like my supervisors and I were just having troubles with her age was trying to teach her to roll on. So, like, I mean, in all this, this is exactly how we should be guiding our residents. And it was a fantastic talk. So, yeah.
Thank you.
Do you teach medical education
Yeah.
reasoning? Or?
I'm trying to get more into it. There doesn't seem to be very much in Calgary. I asked if I could set up like a longitudinal course on clinical reasoning, but they haven't had a lot of appetite to do it. But I'm trying to connect with other medical schools. I'm actually going to go to UBC, and I've got a presentation at 2:30 because I've got a website, teachingmedicine.com.
Okay.
Check it out. I'm going to be building a clinical reasoning section where it measures the decision making as you analyze data and allocate the data as increasing and decreasing the probability of your differential. You can modify, and then it'll let you order tests, and then it'll force you to justify the test, and then it'll give feedback to the user. This is the financial cost. This is the time cost to the patient. These are the risks and exposures that.
But I always like I what I always do with the med students for the insurance, I always say, ignore what's been given to you and say to yourself, what do I need to do? And then the other stuff, you have to look at it. Because you get this thing, you can't ignore it. But you have to decide you want to park this information, like not pursue it, or maybe like something that comes back incidentally very evident, we have to ignore. But so there's so much, like we're not choosing wisely. So much gets done that doesn't help us move things along.
Exactly.
Are you still doing anesthesia?
I do. I'm about a third anesthesia and 2/3 ICU.
Oh, you did ICU.
Yeah.
Okay. Great. Well, teaching.com.
Teaching medicine.
Teaching medicine.
Yeah, you know what? I've got Waechter cards. I forgot to bring. Actually, I might have some.
I know it.
I think I could try and remember that.
Just Google my name and
Or just text me.
That was such
Yeah, cool, eh?
Oh, thanks. Appreciate that. Great to see you again. It's been like.
Oh, were you?
7 years ago? Yeah.
And we did ICU.
Yeah, I know. You walked by and I was like, Andre, I thought that was. Yeah, great to see you. Thanks. Yeah. You lab medicine here?
Yeah, that's right.
Yeah. Well, thanks for coming.
So you guys were in med school together?
Yeah.
Oh, is that right?
Yeah.
Yeah, right on. Our lab connection. You're going to actually get ahead of it.
On a provincial level, but as STEM.
Okay, right.
Do you want to start more lab or less lab?
Yeah, let's let
Oh, okay. I'm not sure
I always
what the incentive is for you guys.
fixed budget.
Oh, it's fixed budget. Oh,
Yeah,
okay.
so less the better. And we're both Aaron and like 1,000 lab tests. We're not more than 30 students.
Well, thanks for showing up and saying hi. Appreciate that.
Absolutely. Great. I'm looking at your website too.
Okay, cool.
Yeah, sorry I won't be able to come to your dinner tonight. I just have a question though about that thinking 1 and 2, right? Because one of the things that strikes me is sort of what you said is like when you're a med student, that whole kind of algorithmic thing where it's like, oh, is it infectious or inflammatory or plastic or trauma, you got this differential. But the reality is, let's say if you go see a patient in the ICU or if I go see a patient in respiratory, we usually do that, right? So, and I don't know what the data is, but I think the most experts or something is all pattern recognition. Like what they do is they ask a few general questions and they say, okay, does it fit in this pattern? Is it a pneumonia pattern or COPD pattern? Yeah, that's what I assume. And during the course of your whatever history, you're actually trying to verify whether that's the right thing. And it's only when you go outside that pattern where somebody says, hey, wait a second, this doesn't fit into a pattern that I know of, then all of a sudden you step back and you know, type type 2, where you go back and you say, oh, I wonder if this is infectious or inflammatory. You know what I mean? You take a step back when you try and look through it, right?
I think as we get more experience, after you make a number of correct diagnoses, the fact that you were correct reinforces it, and then you can turn that into a shortcut. And the question is, when is that going to?
Oh yeah, and then that leads to problems, right? Like on the one hand, it's good because it's really efficient. On the other hand, it leads to these errors that you talked about, where you just saw a guy go down or whatever, and so the next guy has the same thing, right? But I'm just wondering, like in terms of the way that you're supposed to think through the problem, I'm just not sure if the way you do it in med school is necessarily the way that you do it as an expert, right?
Your call will be disconnected.
All holistic. It's all like shortcuts and that kind of stuff. That's like 90% of it.